Show a quick case, just to put you on the spot, everybody. And this is an osteoporotic burst fracture. And yes, the pelvis will come into play. And yes, we have two UCSF colleagues together. As always, we want to kind of have our decision matrix in play, risk-based triage versus high, low-risk procedures, and what we can. And again, the four variables: resources, surgeon experience, injury severity, patient factors. This is a real-life story. This is, in a way, tragic story. It's a 46-year-old female. She sat down 3 months ago, and she had a snap in her back. Now, the real tragedy is this patient actually is and has been for years, I think a decade, on high-dose steroids for a autoimmune disease. I'll just give you my personal thought behind this. I think that she's actually steroid addicted, and I've now had a couple of patients with steroid addiction. Sounds crazy, but I actually believe that this is real. And so she's, I forgot the number, but it doesn't matter. Assume that she's been literally on a decade-long steroid regimen, and she's bedridden due to pain. We literally got called on the usual Friday evening before a holiday weekend on this patient who'd been in the hospital for a crazy period of time. She had an open ulcer over her T11 spinous process that went all the way down to bone, that had been treated by the wound care service for a while with whatever miracle salves that did not work. And she had been given a brace by somebody that she did not wear because it actually rubbed against her open wound. So she was literally curled on her side. She's neurologically intact, so she's Asia E, motor score 100. Hounsfield units versus DEXA, Dr. McGuire. What do you do? What do you teach at the University of Mississippi? And have Hounsfield units now actually overcome the need for DEXA scans?
Yeah, I really like the Hounsfield unit, and the beauty of that is that you've got an index, and it's hard some places to get a DEXA, and but the patient comes to the ED most of the time. You get a CT scan, so the Hounsfield unit to me is a primary. Plus the type of the fracture. If you got a low velocity fracture, that kind of preempts all the need for the DEXA anyway. With you've got a Hounsfield unit that's 80 to 100, then they have a fracture. That's an osteoporotic fracture from my standpoint. So I don't really push to get a DEXA unless I'm down the road and I'm treating that. This would be a very interesting patient. My question to you: has anabolic been used as far as treating this at all? So that's going to be the first thing that I would see in this patient, that I would say, let's get the anabolics on board, because we're going to have to do something to be able to create stability.
So
let's make some bone
here
graft.
in this group, this is a classic example of our failure of providing systems care for patients who have a predictable disease entity that should be screened for, and that's not happening. So this was a disaster waiting to happen, and should have been prevented in the first place. She should never be on steroids. I mean, I'll give it away now, 6 years of knowing her, or 7 years, something like that, there's never a cognitively clear autoimmune disease that I could put my hands on. This was always kind of a nebulous paranoia, and sadly there are providers who underwrite that, they support that. On a logistics basis, maybe I'll ask one of our UCSF colleagues that we still need to have a DEXA scan rather than a CT scan to validate the use of anabolic agents. Why is that?
I think that's probably mostly driven by the logistics of getting the medications approved. I mean, clearly clearly she has this is a fracture in pathologic bone, so it's a frailty fracture, so she's osteoporotic, but the DEXA does, sort of help provide a baseline for once you treat with anabolics, if there's a response, so.
Do you in the Bay Area have a better model system to try to screen for this patients? Like, do you have your radiologists get opportunistic Hounsfield unit scores from the spine to kind of see at-risk patients and then send them off to the primary care doctors for preventative care?
At least in our, in our trauma network and our, that's not a routine, but it takes, some additional resources, but I think those would be resources well spent in terms of identifying and preventing diseases or injuries that we could otherwise, sort of prevent.
When I was president of the Washington State Orthopedic Association, we actually made an effort in my 2-year term to try to get the national radiology organizations to add this to their things. They have simple algorithmic things, and they could literally just click on that, but we want chest CTs and whatever, abdominal CTs to be used as a preventative measure, and any x-ray of any extremity could be also screened for this, but it's there was great interest from the radiologists, and after my term was over, it's poofed away.
Yeah, I mean, you'd think with the auto segmentation abilities that this would be an easy software solution,
I won't think so. Dr. McGuire, you've been president of AO, and a lot of this had to do with bone. Is there any hope to get some systematic approach towards this pervasive disease that's hit so many countries around the globe?
It's very interesting because it's resource-oriented when you look at it. We've got the data. This, Stefan Perrin, and they did this whole osteoporosis protocol and investigation, and so we know what goes on with the bone. We know what we can do to treat it. The problem is the resources within multiple regions, and just like you're saying, at our hospital, it would be so easy for the radiology folks to add this, but who's going to take care of it? Rheumatology, you're trying to unload patients to the medical care, and there's just no resources available. So we're getting a little bit better within this, North America with having osteoporotic clinics. So, that came from the orthopedic literature where we all fail. And so we realize that when we look at the data, that we've got to do something a little bit better for our patients and being able to manage this process. Globally, it is a huge issue. You go to Japan, their osteoporosis issue is bigger than ours. And those are the countries that talk about it. We've got it in every country. You go to, the Middle East region, they have the same issues, but it's a research or a resource problem. And I don't know how you fix that. From the government standpoint, how do you make sure that there's enough funds available to manage all this? Because we're an aging population. If you look globally, the white tsunami is coming. I mean, the gray tsunami is there because we're all getting older. The global population is getting older. So this is going to be a huge, huge problem just from a resource standpoint financially. We know what we need to be doing. But is it going to happen? I don't know. I don't think until the people raise enough cane about it to say, look, we need to fix this.
Whilst you have the microphone, I'm going to ask you one more question before I go to Amir, and that is, you've obviously been not just a very successful educator and leader at the University of Mississippi, but also a very successful medical politician. What happened to AOA and the Own the Bone program? That cost several million. I donated to that. One of my mentors, Paul Anderson, ran that. And that basically tried to democratize and simplify osteoporosis care. What happened to that?
That was a great program. And I thought at this point, again, that was data-driven. We looked at how we were treating this patient population, and we were failing. So we, as an orthopedic association, we got an F. And so that's what really started the ball rolling. And again, everybody jumped on board, and the funds ran out. So now all of a sudden you've got the information is there, but the resources become, scarce. And so I think that's one of our problems, is that we go through one phase, we kind of think, okay, yeah, this is going to be okay. We forget about it, and then it just dissipates. And so I think that's just the nature of the beast that we're dealing with. I mean, we've got the information. We know that if we treat these patients with anabolics, that they get better. and then you can actually fix them, and they really do very well with that. The problem is getting who's going to pay for it. You know, most of the folks in our country, it's Medicare, Medicaid, and trying to get somebody, you know, certified for this medication, you're writing letters, and it becomes onerous just as a clinician to, you know, to go through the hoops to try to get the patients taken care of. So I think until we make some changes within that process, and, you know, I think it's just going to take enough of us, you know, pounding on the doors and talking to our Congress people. And of course, who knows how it's going to change with this new process, but you know, I think that's where we're going to have to deal with. This is a financial, logistical nightmare.
But let me just harp on that one more time. That's the AOA basically tried to have mid-levels deliver largely risk-based algorithmic care. So 80+% of patients with routine osteoporosis could be treated by mid-levels. Absolutely. And only the 10 to 20% of complex patients with medical comorbidities, whatever they are in this patient, and oncologic diseases where there are contraindications to anabolic agents would come out. Why did this not happen? It's not.
It's very
interesting. You can't tell me it's money.
Why should we pass this on? This was my argument all along. I mean, we're the bone experts. Why should we pass this to a primary care guy? Why should we pass this to a rheumatologist? Why can't we do this ourselves? I mean, we're managing this thing. I mean, you know, we're more than surgeons. I mean, we're orthopedic physicians. And that is a real issue that we have clinically. I mean, I would see patients coming in. I had no problems writing prescriptions for anabolics. I mean, hey, this is a fracture. This is a real issue. I've got an osteoporotic fracture. I'm going to treat the osteoporosis.
Are you also going to be the one that
Microphone.
Yes, I'm going to be the one that follows. Absolutely.
Yeah. So the most prevalent bone disease in the world. Now I should send all those patients to you.
I would be more. It was very interesting.
Microphone.
Because I talked to the folks in at Wake Forest, and they were very successful in putting together an osteoporotic clinic. Mm-hmm. And they had a mid-level provider. They had, you know, the endocrinology. They had rheumatology, and they had an orthopedist. So I said, that's really a pretty nice program. So I tried to mirror what they did in Mississippi, and it was really working well till I retired. And then all of a sudden, nobody wanted that. So it really, where our issues come, you've got to have somebody driving it. And I always think it's better to have an orthopedist driving it than, you know, one of the other medical providers.
So Amir, so you do a fair bit of deformity surgeries, and how long do we have to wait until an anabolic agent takes effect? And how easy is it for you as a practitioner to actually get these medications approved?
Yeah, before I go into that, I just want to say, you know, as orthopedic surgeons, we are a surgical subspecialty. You know, we get into it because we love the art of orthopedics. And unfortunately, there are a lot of people out there that are not interested in writing prescriptions and want someone else to be doing it. So I think, you know, just the idea that us as orthopedics, like you mentioned, if we're the head of a team that's doing it, I think that has the potential to have a big impact. But this is a society-wide problem, and us as a, you know, unified, you know, individual specialty are not going to, unfortunately, make a big enough difference to really affect society, which is needs to be changed. But yeah, in terms of the anabolics, you know, from the data I know, they've shown that as little as 3 months can make a difference in terms of changing someone's outcomes, in terms of maintaining their deformity correction and getting a stable fusion. I think that's kind of the bare minimum. You know, these drugs do take a long time to work. And so we need to give them at least that much time. And a lot of times patients don't want to hear that. But, you know, if you do want to have a successful outcome, you know, you really have to give the medication the time it needs to have its intended effect.
Bisphosphonates versus anabolics.
So we need to kind of move forward with this
question.
case. Ashraf, comminution index applicable here or not? What is this? How do we approach this now in a conceptual manner? Aside from the fact that it's an open fracture with a pretty grotty looking, despite embryonic stem cell granulates, whatever, this is an ugly looking snotty wound. The patient is not septic.
Yeah, I mean, this is just bad. So, I mean, she has collapse. It even looks like there's a difference in the amount of kyphosis between two supine studies there, between the MRI and the CT scan. So this is functionally unstable, and it's a failure of the anterior component. I think the posterior is just it's a wound issue. I don't think that was because of any blunt injury, right? So, this is, it's something that we need to provide, and she's having functionally limiting pain, right, which is driving all of this. It's driving the ulcer. It's driving, sort of her.
So unstable equals surgery, staging, close the wound?
It just means, so I think the wounds, I think we treat the two sort of separately. I think the thing that if you take a step back, what I want to do is I want to get her to a position where she's not in bed all the time. That's what's sort of driving this. And so what is it that's causing pain? Is it just the persistent micromotion at the level of the injury?
I mean, for me, the White and Punjabi criteria is exemplified here.
Yeah.
I always tell our fellows,
Yeah.
do you want to assess stability, instability in a neurologically intact patient? Sit them up, watch their eyes. When they're comfortable in bed and they get up and they start freaking out. And this patient, all the steroid craziness aside, clearly had that. She was unstable, even with the brace, which again chafed her backside down to the bone, literally.
So I think we need to provide some stability to this. The question of, a surgery or something percutaneous or simple cement augmentation. I don't think there's much data for this specific patient, but there are clearly risk profiles, and the risks are different for each of those approaches. This is a problem that's 3 months in the making, and so we don't need to find an immediate solution. I think if pressed to the fire, I would, have a discussion with her and would favor potentially just trying, sort of cement augmentation initially as a MIS sort of approach to provide some stability so that we could get a handle on her wound, get that healed up. And if that fails, then we've bought some time for a bigger procedure.
So, Amir, you're the cement advocate. Is there any hope to get that cement in there? And what is this pathology, actually? This is not a neoplasm, but is there any hope for cement here?
To me, this looks like it may be Kamel's disease, just with the cortication that we're seeing. And you can see actually on the coronal, there's just kind of a, vacancy there. Will putting cement in there give her some increased stability and allow her to get up? I think it's possible. But I mean, the hope of this healing, I think we're far past that.
So, what are you going to do? No cement, wound healing?
Right now, I mean, I think this patient needs nutritional optimization. She needs, anabolic treatment. Try to get her some wound care, different brace that does not chafe this, if possible, to get her moving. But, I would not operate on this patient right now at this point.
That was my instinct also. Dr. Gendelberg, a cementless screw fixation, percutaneous. Come on, everybody's kind of dodging.
I think the host in this case is a big factor. I think before we do anything operative, we do need some nutritional optimization. As Ashraf said, it's been going on for 3 months. Sometimes we do want to help this patient immediately, but we also know that we could make it much worse. And so we at least want to optimize our deck of cards as much as we could.
Dr. McGuire, so 3 people say nutritional optimization. Any role for getting in there?
Yeah, I agree 100% with the optimization. But I mean, what if this were an infected non-union of the tibia? How would you manage that?
Good question.
So I think what you're looking at is that we've got instability and we've got a posterior wound. We don't necessarily have anything infected up front. So I'm going to optimize the heck out of her. Nutritionally, I'm going to go to make sure that we're good there. We're going to go ahead and get the antibiotics. This is a beautiful case for a reconstruction anteriorly. Put a plate on. I stay away from the infection in the back. I've stabilized the spine, and then I can address the wounds at that point. But I think you do have to optimize nutrition and get the bones going at that point.
So I struggle here. So the count is 0 for 4. I'm going to be a switch hitter, which I always love doing. Go to my neurosurgical colleagues, Dr. Ramey and Dr. Hofstede. I'm going to bring the microphone to you. Nutritional optimization. This patient has been in-house, I think, for 4 weeks. Oh, here, I was going to bring this go. 4 weeks plus on the medicine service without any spine surgery consultation. And she's literally gotten jungle rot disease now. And she's gotten the in-bed plus steroid psychosis duo. So continue to nutritionally optimize. I'm mocking my 4 ortho colleagues right now, and see what we can do. Maybe a little cementing, maybe a little... Come on, give me some counterpoint.
This is obviously not a good situation for anyone, for us as surgeons and for this patient, clearly. But I think you're kind of in a situation now where your hand is really forced. She's got an open wound, semi-infected, it sounds like, and she's actively unstable and severe pain. I don't think she's going to get to a point without operative intervention of being optimized without surgery. So I think I would do this posteriorly. I would go 2 up, 2 down, cement to augment my screws. I would have plastic surgery with me to close the wound and get really good muscle flap coverage over this chronic open wound. And I would also do a little bit of an anterior column reconstruction, do as much of a corpectomy as I could by taking down the pedicle and maybe the rib head on one side and placing a cage in through there. And then, of course, hit her hard with anabolics and nutritionally optimize her all you want to after that.
It's like the board exam answer, optimize, non-operative. Dr. Hofstede, so Texas came to my rescue. It's 1 to 4. I need another help here.
Well, as you know, Jens, you've been there. However, we see this all the time. I think as surgeons, we sometimes don't have to be overly smart. There's simple answers here, and I think like this patient has been lingering, waiting for the DVD to find its way into the lungs, and so I think this is where a higher level of care is really coming in, where you have the team approach. Plastics can close any wound. I would do a transpeculiar corpectomy after a cement in the base. So you basically cement on T11, L1, cement the base, put the cage in, restore the kyphosis there onto the cement. And then 2 or 3 up, probably 2 down at least. It doesn't matter. Cement in those screws, and then have plastics, do rotational flap or something else, cover that wound well, and move on. And then obviously down the line, but we all know how the American healthcare system works. Nobody has money for real care that matters.
So I think if we're going to consider a corpectomy, I think for this one, just I would probably go laterally, so transthoracic. You already have an open wound posteriorly, so a transthoracic approach. So you're not going through a wound bed. You don't have to rely on muscle closure. You could perk screws around it to support it. Let that wound heal. You could see there. She has no muscle to close. This is a dream to say that you're going to have, because you call someone else, that they're going to be able to close over the wound. Sure, they can mobilize it, but it's going to be under a fair amount of tension. So I think if you get her to a point where she's nutritionally as optimized as possible, and that could be a few weeks. Get her some calcitonin. Then I think if doing a corpectomy, I'd probably approach it from the lateral.
Okay. Interest of time, because we have the dynamic duo hit this. This is what I did. And we did it like the next day, because the head nurse of the floor came to me and said, can you help us? There was a mutual psychosis escalation between the nursing staff and this patient who was fighting a war with everybody. So because she refused to lay on her back anymore, she's literally rolled on the side. So I just said, screw it. We have a plastic surgeon who's very good. This was on a holiday weekend. He was not there. So I just did it myself. I excised everything wide. I did whatever fascial closure I could. I worked at Harvard for 25 years, so been there, done that. And this is what we did. So is this going to survive or not, David Gendelberg? I used cement. I had no leakage. I was pleased.
I mean,
Microphone.
I mean, in all honesty, in this case, I would use cement as well. This needs to get everything we could get. And as I said, I'm not anti-cement. I'm just think we overuse it sometimes. But I think this is a case where it's appropriate to use it if you do approach it. Whether it will survive, I don't know.
Amir, we need to do rapid fire now. We need to kind of get this concluded. What's the evidence base for cement of UIV and LIV minus +1 respectively?
There is some evidence to say that it can slightly reduce the risk of proximal junctional failure and things like that, but not all that strong. Again, the technique really matters. What your soft tissue preservation, I think, probably matters equally as much. But for a patient like this, you want to use every tool you have.
So I'm giving you a little foresight here. The DEXA scans over time, despite anabolic agents, decreased. It's minus 2.4. Bob, you're the wise guy here, the silver hair. Is this going to survive or not? So I'll tell you one thing, she did not get infected. I did a great job. Dirty Instrument said, I used exactly the analogy of infected lower extremity fractures. Resected everything that was dirty, wide excision, multiple washout leaders, and then new instruments went for it. Is this going to survive or not?
Yeah, I actually like this. I wouldn't have been as aggressive posteriorly as you. I would have gone anterior, and I would have done exactly what you did, and I would have probably augmented with the cement. I probably wouldn't have gone posterior with instrumentation. Who knows? But I think this is probably going to survive. Now with the anabolics and stuff, we're in the process of trying to get a study looking at proximal junction because we were doing decreasing doses of cement, and what we were finding is that you minimize the risk of the supravertebra crashing up above by using a decreasing dose of cement over multiple levels. And we're having a hard time finding that. People think it's too aggressive. I don't understand why the editors feel that way. But anyway, I think this is going to be fine.
Amir, thank you for the nothing hurts follow-up but follow-up. So, Amir, with these osteoporotic patients, one thing neither you or David talked about is, should we try to do short segment fixation because the lever arm is less on the adjacent segments, or do we have a little bit more give with, again, adjacent segment cementing?
I think in a nutritionally compromised patient, the steroids to add in, you can try to do a longer construct, but whether they fail, I think, is more the host than the actual length of the construct.
So I went for a relatively short construct, and this is, again, 3 years out. And she steadily came back to clinic because she wanted to tell me that she needed a long fusion, and she wanted to be fused to the pelvis. This is 6 years out, and she's still on sky-high steroids, and she never had an infection, and this is her round back. She's still sarcopenic as can be. And am I going to fuse her, Ashraf, to the pelvis?
No.
In so many words.
Yeah. No, I mean, I think I think she's lucky to have made it this far with those radiographs at 6 years, given her risk factors. So, I think we're, and I'm sure, so I think we take our win and move on. That's
my point exactly. I reiterate and literally cut and paste with exclamation marks my previous notes and say this still applies. The frustrating thing was she's been on and off anabolic agents and anti-resorptives now in steady mixes, so the pharmacologic efforts have been there, I think. The steroids still remain crazy high, and we have the same discussions in iterative fashion, and there's always a well-meaning provider who thinks that there is an autoimmune disease that this needs to be suppressed with. So so far, so good. She never got infected. So I really like that analogy of Dr. McGuire, because my mentor, Dr. Ted Hansen, always taught us that don't be afraid of hardware infected patients, debride them and fix them. And that was his paradigm. And I got away with something probably, but I'm not super happy with this, but I'm absolutely not going to give her a sagittal realignment, because that'd be T2 to the pelvis, and it wouldn't stop there probably. Any thoughts,
Hey,
Dr.
Jens,
Ramey?
No, that looks great. I mean, I think this is a win for her.
I thought so too. Dr.
So,
Hofstetter.
One question. I mean, how much do you think a lateral cage would have given you there? You know, T12. I mean, possible. I just, again, I think, you got a very nice restoration, which you typically get at T12 because you can actually even take the nerve root there if you have to, which you typically don't, but you can. Any benefits there? I mean, I'm always worried about getting a second scar and then you have to deal with the diaphragm and some other issues. They're harder to mobilize afterwards. It comes with a whole bag of issues. What is
So great question. So first of all, our ex-lift magician is not here, Dr. Oskuyan. We actually showed 2 cases last night, and he is a magician. We have a very nice paper coming out from one of our fellows. We did a very extensive cadaveric study, and the upper lumbar spine, including T12, is totally safe for far lateral procedures. It's actually very nice. Our fellows did these surgeries. We just supervised them, and the anatomic landmarks and everything are very, very impressive. So our lab did that. So nowadays, or had he been available on a holiday weekend, not there, I would have asked him to do a far lateral procedure. The end plates are clearly better. We showed a case last night where the dual cages, cervical cages, in a L3 area where we could not sacrifice nerve roots. And we basically did 2 cervical expandable cages, slipped them horizontally in, tilted them, and verticalized them. So I can show you that this is a dual cage construct that I, as a poor guy who is afraid of doing far lateral surgeries, do as a poor man's recipe.
I just want to say, I do lateral cages as well, and sometimes will want to stage these myself. I think that 2-cage technique is good because if the blood loss has been low, you can just get it done right there, and you're saving the patient another anesthetic event or another couple hours of surgery. So I think that technique is a great one to have as long as the patient remains stable.
Great. So we are a little bit behind time, but I thought this was an important discussion. Thank you all for coming together. I'll ask the dynamic duo to come up here. So a double hit from UCSF, Ashraf and David. Give us a double lecture on MIS and spine trauma.